If you ever need to understand anything blocks, go back to this diagram. Go back to the conduction system of the heart. And we will be talking about how that translates into the ECG. When we come to the U wave, the U wave is an extra wave after the T wave, but we want a QRS complex to be narrow. And by narrow, I mean it should be less than 3 small boxes. If ever an ECG QRS complex is wide, then it is abnormal. Always abnormal, right? It can also be wide in VT. It can be wide in Wolff-Parkinson White. What do we know about our Wolff-Parkinson White? In Wolff-Parkinson White, the PR is short. Short, that means after today, ECGs will never be confusing for you. Because once you understand the 3 pillars of ECGs, there's simply no ECG that you will not be able to make sense of. Let's get into it. Hello and welcome to the YouTube channel. On this channel, we break down ECGs so that they are stupid simple. If you're new here, please let us know what part of the videos you found helpful. Share, subscribe, like. And yes, here we go. Any ECG that ever lands on your desk will fall into one of these 3 buckets. Either it's a conduction problem, or is an ischemia problem, or it is a structural or metabolic problem. And you can literally rehearse this anytime you see an ECG. So let's get into conduction, right? With conduction, what we are asking ourselves is our impulses traveling in the heart. And with your knowledge about conductions, this will sort out any problems you have with blocks, with understanding intervals, and it can also overlap with the other pillars. But let's make this stupid simple so that you don't ever miss any conduction problem on an ECG. So first we have this lovely drawing drawn by yours truly. My son thinks it's a nice drawing of the heart that I've made here. But yes, it kind of gives you a cross-sectional view of the heart. So if you slice the heart from top to bottom, this is what you will find, right? And I really did not highlight any structures here. It's just a simple drawing telling you what is the conduction pathway and what nodes or special groups of cells are involved. So here we have the sinoatrial node. The heart is a very beautiful organ in the sense that it generates its own electricity. And when this electricity travels from one part of the heart to another part of the heart, it sends a message to the heart. It says, beat now, beat fast, beat after me. And so this one right over here, which you will find in the sinoatrial, in the right atrium, because here is the atrium and here we have the ventricles. As you know, there are 4 chambers of the heart: the right atrium, the left atrium, the right ventricle, the left ventricle. So this sinoatrial node is what I would like to refer to sometimes as the president of a country or the principal of a school. So if you think of the sinoatrial node as the president of the school, he runs the affairs of the country, right? And he does it pretty well, ideally very efficiently. But the day he falls sick or something is wrong, the vice president takes over. Your AV node is the vice president. And it may not do the best job that your sinoatrial node, but it tries, you know. It may be slower in generating impulses, but ideally it's meant to be slower, right? And you know, this has been beautifully designed in such a way that when one part of the heart is failing to generate that impulse, there are other assistants that take over. And now, so if the vice president is not working, the ministers take charge, right? And in this case, the ministers are other nodes and points in this heart, which we will not be able to talk about today. But just know that, for example, the Purkinje fibers, which are these lower little branches here and are not supposed to be doing any job of conduction or any job of generating impulses, may also be able to take over. But if you're getting to that level, the heart is probably, you know what I mean, the heart is gone, right? So how does it work? In a normal heart, the impulse will travel from here to here. Simultaneously, it's traveling to other parts of the heart. For example, it's traveling to the other left atrium. A lot of simultaneous processes are going on. So think of a sea, a wave, you know, passing through an ocean. The impulses move or the current moves. As it moves from one part of the heart, it goes to another part of the heart. So the current moves from the sinoatrial node to the atrioventricular node right across the atrium. And that is what is represented in your PR interval. So when you see that ECG and it's showing you a PR interval that is prolonged, it means there is a delay. Something is going wrong in such a way that there is a slight, maybe not necessarily wrong, but something has happened to cause this flow from here to here, right? And here, it could be that your sinoatrial node is sick. That's what we call your sick sinus syndrome, or there's a sinoatrial exit block, right? So if the impulse does not start, everything else downstream can be way quieter or slower or more delayed, right? And that is why I find that understanding this really helps you. Now, when you have these impulses going to the sinoatrial node, it can travel, as a bundle. And this is what the bundles are. Now, the left bundles, right, can come to the right, can be split into the two. And so this is where I labeled this as the right bundle branch block, right bundle branches, sorry. And then this is the left bundle branch. It's coming from the bundle of ACE, right? So it goes into two, one to the right and one to the left. If there's a problem at the level of this AV node, you might have an atrioventricular block. And remember, if you watched other videos, I talked about your first degree ad block, your second degree ad block, Mobitz type 1. In Mobitz type 1, we said the PR gets longer than drops. It's because there's a problem here with the atrioventricular node, because it's becoming increasingly fatigued, increasingly wearing, and until it can no longer conduct impulses to the ventricles. And that's why your QRS eventually disappears. So I hope that made sense to you in terms of interpreting the working back. But this particular this particular diagram can go on to explain loads and loads of all the blocks that you can ever see on an ECG. Now, if there is a block occurring at any level below the atrioventricular node, you can have your second degree ad block, Mobitz type 2, or you could have complete heart block. And that is where it gets dangerous, because if a block has happened to any part of the system, to this level of the system, that means, we are getting to a stage where the heart is diseased. And a lot of things could be causing it. It could be medication. It could be a heart attack. It could be ischemia, right? And, we're going to talk about ischemia down the line, right? So just to summarize that point so far, this is the normal conduction pathway. Well, here. And so, trying to find my ruler. We'll get someone to get that for me. But here, 1 to 5 is how the heart would normally behave. If there's a problem here, we talk about sick sinus syndrome, sinoatrial nodes. If there's a problem, also moving from here to here, that's where you will have your problems going on there in terms of your blocks. If you have a problem with the AV node, so if you have with the PR node, it will be your primary ad block, your first degree ad block. With the AV node, your second degree ad block, Mobitz 1. Below the AV node, around this, between here and the bundle of ACE, you could have the secondary degree ad block, Mobitz type 2. Now, if there's a block at the level of this place, at the level of the right bundle, what do you think will happen here? You got it right, the right bundle branch block. And that is where we talk about the Marrow-Williams. That's your RSL prime in V1 and your W, right? Another pattern going on in your V5 to V6, or your RS pattern going on there. So you could take basically quite a number of forms in your V5 to V6. Now, if there's a branch block going on here at the level of the left bundle, what are you going to have? You're going to have a left bundle branch block. Now, if, as you can see, the left goes to the anterior division and the posterior division. The left anterior division is what we refer to as the left anterior fascicular block, while this left posterior division is called the left posterior fascicle. If there's a block, for instance, in your left anterior fascicle, that might cause you a left anterior fascicular block. Are you still with me? I trust you are, because if on the other hand, there's a block at this level, then there's a left posterior fascicular block. But it gets even more interesting, because if, for instance, you have a diseased heart that is so compromised in such a way that there's a block or a problem here, that's one. And then there becomes a problem with the left anterior division or left anterior fascicle and 2. Then that becomes a bifascicular heart block. And I bring this up because I get a lot of comments with people confused about what a bifascicular heart block is. It's simply that there's a block going on in 2 places, your right bundle branch and your left anterior division, right? Also, if you have a trifascicular heart block, right, it's going to be a bifascicular heart block with a prolonged PR interval. So your bifascicular can either be a right bundle branch block paired with your left anterior fascicular block, or a right bundle branch block paired with a left posterior fascicular block. And I hope that makes sense to you. Now, I've said William Marrow can be RBB, Marrow William can be RBB, while William Marrow can be left bundle branch block. Now, this, like I said, will sort out anything blocks for you. If you ever need to understand anything blocks, go back to this diagram. Go back to the conduction system of the heart. And we will be talking about how that translates into the ECG. Now, we move on here. Now, this is probably one of the most well-taught, scariest parts of ECGs that people know. Not necessarily the scariest of ECGs, because it's so well thought that you would be able to pick out most cases of ischemia on an ECG. However, I think the trouble comes when you have the rare patterns, the De Winters, the Wellens, the things that don't classically present as they should, and then one might begin to panic and say, oh, non-specific ST changes, what are they? But we'll break this down again. Now, this is another beautiful picture, but this is just the outer picture of the heart. It kind of tells you where each artery goes. Now, we know that in ischemia, the trouble is that oxygen is not getting to the heart muscle. The heart muscle is an organ. It needs oxygen by itself to survive, to do its function. Now, if at any point in time it's not getting enough oxygen to help it do its function, it's going to misbehave, simply put. Excuse me. So, ischemia just means lower oxygen getting to the heart. And if it goes on, it can cause injury, right? And it can cause infarction, which injury can go on to mean infarction, which means death. And at this point, I'm just going to pause and let you know exactly the concept of ischemia. When we talk about ischemia, because this is something that every single doctor, I don't care if you're a cardiologist or, you could be a medical student, being a medical doctor to be, every single medic, not just a doctor, needs to know about ischemia. And a lot of people have found this confusing. So for the expert people on the group, I want to break this down to you, because it's under ischemia that you have the so much dreaded heart attack. If a patient has chest pain that is coming from a heart attack, it's in 2 broad categories. It's either an acute coronary syndrome or a chronic coronary syndrome. If it is an acute coronary syndrome, then it's a medical emergency that needs urgent, admission, urgent intervention. But if it is a chronic coronary syndrome, then it doesn't probably need, it's not an emergency, but it would still need some kind of medical intervention to prevent it from being a medical emergency. So when you think chronic coronary syndromes, think about stable angina. So that's what stable angina means. In most cases of stable angina, the blood pipes, which are the arteries, you might hear me call them the blood pipes for the non-medical people in this group or that are watching this channel, you will find that the blood pipe, which transmits blood, which carries blood, and the blood carries oxygen to the heart, is occluded, in many cases, by 70% or more, right? And when it is occluded up to 70% or more, many times it's coping well. If the patient is resting, is going about their regular activities, there's demand is meeting supply. But if the heart is struggling, for instance, if the person is exercising or their emotions are very high, and the heart needs more oxygen, then it can struggle. So in a person with stable angina, they will have the typical constricting, central or left-sided chest pain, traveling to the jaw, traveling to the throat, and then they can be cold, clammy, but this chest pain will be relieved when they are rested. It will be relieved with GTN spray. It's because they are atherosclerotic plaques, which is just another name of a lot of bad cholesterol that have caused a 70% or more blockage in the vessels of the heart. And that is why they will tell you use statins and all of that, but that's another topic. So basically, if it is a stable angina, then we can afford to refer to the cardiology within a reasonable time period. But the trouble is when it becomes an acute coronary syndrome, which can be an end-STEMI, which is your classic heart attack that everybody knows about, or can be unstable angina, or can be, STEMI is your classic attack, end-STEMI is myocardial injury. So let's go through this and we will come back to this 1, 2, 3 things that occur in an acute coronary heart problem, an acute ischemic problem. So what do we have here? We have the aorta, then we have the right coronary artery and the left coronary artery. Some people will refer to the left coronary artery as the left main coronary artery. The right coronary artery branches off and branches off until it gets to the right acute marginal artery, while the left coronary artery, which as you can see is the main artery supplying the anterior aspect of the heart, will then branch off to form the circumflex artery and the left anterior descending artery, and which also branches off to the diagonal arteries. Now, when there's a problem, let's say this blood pipe is blocked, completely blocked, for instance, by a ruptured plaque. We talked about this bad cholesterol that forms in the blood pipe. Sometimes that bad cholesterol now ruptures and then forms a clot called a thrombus to absolutely block the artery, this major big vessel supplying the heart. What will you have in that case? What you will have is a global ischemia, and this is what I've highlighted here. This is very high risk because this artery supplies a very big part of the heart. And in this case, go look at your AVR. There will be ST elevation in AVR and diffuse ST pressure because you've just injured the heart on a massive scale. Now, let's assume that the rupture of that thrombus. Now, as I'm going through this, there's a lot of things coming to my mind, but please, if you want further explanation on the acute coronary syndromes and the chronic coronary syndromes, and how to differentiate a non-ST elevation MI from an unstable angina from an ST elevation MI, just give me a like and give me a comment, and I'm happy to signpost you to the video that breaks that down in the most simplest, stupidest 5-year-old level terms you've ever heard, because every medical person, you call yourself a medical person, you need to be able to distinguish all three. Now, let's talk about if this blockage happens at this level of the right coronary artery. What happens here, my friend? The inferior part of the heart. As you can see, most of the branches of the right coronary artery are supplying the inferior part of the heart. And what happens here? You have inferior ST elevation MI, which causes an infarct. An infarct means death. It means the whole thickness of the heart, which is the transmural aspect, is dead, right? If, on the other hand, you had a blockage here of the left circumflex artery, what happens? You have a lateral ST elevation MI. And that's where you have one AVL V5 to V6 with a lateral ST elevation MI. It can also occur with posterior myocardial infarction. Now, let's talk about the left anterior descending artery. We've talked about the left main coronary artery, but the left anterior descending artery is another offshoot of this left coronary artery, right? And so what happens here? What happens here is V1 to V4. You have ST elevation. We talked about the J point. It's going above the J point, above the isoelectric line. So, and that is also where you have problems like De Winters and Wellens, which I've explained in other videos. Now, what do you get? What do you get? What do you get? If you do not have a classic ST elevation MI, I'm quite confident that most people will identify ST elevation MI and activate the cath lab. However, the problem comes when there is no ST elevation MI. As you can see here, if this is the isoelectric line, and that is why having an ECG ruler is very helpful. If there's an ST elevation MI going on here, you can see that this is the picture it will present. But if there's no ST elevation MI, you can have any of these changes. I'll label this 1, 2, and 3. You can have 1, 2, and 3 in non-ST elevation MI, or even in unstable angina. What differentiates these two is whether your troponins have risen or not. So, in the winters, you have upsloping ST elevation in V1 to V6 with hyperacute waves. We've dealt with this before. And in wellies, you have biphasic T waves in V2 to V3 and deep symmetric inverted T waves. What is really important to know in all of this is that the first clue you may have in a patient with an evolving heart attack might be your hyperacute T waves. The second thing you need to know is that this might be followed by T wave inversion and then progresses to ST depression. When you see a patient with pathologic Q waves, it means that they probably have had a heart attack. It means an old heart attack, an old MI in many cases. Now that we've covered the ischemic portion, and believe me, you understanding ischemic portions of the ischemic causes or ischemic problems in an ECG will prevent every medical legal issue, well, most medical legal issues that you can deal with, because your ability to pick up an ECG, and you know, this was big for me because when I restarted clinical medicine, I was worried about missing a heart attack. And that started my ECG journey. So whatever you do, as long as you call yourself a medic, try and understand this particular pillar of ECGs. Now, with the others, we may be able to buy ourselves more time, but they're still very important because taking the best action will help you treat your patients the best way they could. So we come to the structural stroke metabolic part of the ECG. Now, with structural and metabolic aspect, remember, your ECG only gives you clues about the electric impulses. It doesn't measure your electrolytes. It's not an echocardiogram that, shows you, but it can give you very good clues. And that is why I always say that ECGs are mere tools. What you need to do is to understand how they work and then treat the patient. So here, the P wave. I'm just going to jump straight into the abnormal portions, because you should know how the normals look like by now. If your P wave is tall and notched, you're thinking left atrial enlargement. Sorry, right atrial enlargement. But when it is wide and notched, you're thinking right atrial enlargement. And what kind of things that cause your atrium to be enlarged? It could be, from overworking of the right side of the heart. Right ventricular hypertrophy can occur in so many things, like your PE. It can also occur from hypertension, from COPD causing cor pulmonale, right? So that's why this is called P pulmonale and P pulmonale, P atriale. Now, in your Q wave, the Q waves can be normal. They can be isolated and tiny in your lead 1 and your lead AVL, but they can be normal in your AVL, lead 3, lead 4, and often also in early repolarization. But they become pathologic if you notice that they are above 25%. They are 25% or above 25% of the R waves in V1 to V3. In that case, please look at that ECG again. If they are less than 1 small square, or they're above the 25%. In your R wave, it's really important that you understand what your R wave is doing. How is your R wave progressing? Forgive me if I don't know how to say R wave well. People say I say R like W, so please just flow with me. R wave should get bigger, should be initially small in your V1 and progressively get bigger till you get to your V6. So we talk about poor R wave progression, we talk about tall R in V1, which tall R wave in V1, if you remember very well, your tall R wave in V1 can tell you that, like I said, your R should be small in V1. If it is tall in V1, there's something wrong going on there, right? If you have low voltage R wave as well, this could be signaling you to a structural problem of the heart. Do you have some pericarditis? Do you have what is constricting the heart? Is there a tamponade? What is really going on there, right? Now with your S wave, your S wave ideally should be deep in V1, in V6. I mean, it should not be deep in V6. if it is deep in V6, so we often talk about recognizing LVH. If you remember your Sokolo-Lyon criteria, your Sokolo-Lyon criteria talks about a deep S wave in V1 and a very tall R wave in V5 and V6, and it even has specific criteria. One of which, if you calculate the small boxes in the S wave in V1 and the R wave in V6, and if it is more than 35 millimeter, that's one of the criteria for your LVH. It can also tell you about RVH. If it is deep in V6, you're looking at right ventricular hypertrophy. If also your QRS complex is simultaneously wide, then you're looking at a right bundle branch block. Now, I hope you're with me so far. To be honest with you, foundational lessons are needed when you're doing ECGs. But once you get the foundation sorted and everything makes sense to you, then you don't see ECGs as just mere graphs or mathematical calculations. It's almost like you can see the heart, like you have X-ray vision, and you can picture how the heart is working once you get this basic sorted. Now, we also know about the popular S1Q3T3. People say this is pathognomonic for pulmonary embolism, but not necessarily so. It's very unspecific. I've seen a lot of people with S1Q3T3s in TCA toxicity, in all sorts of, and that is why this heading is not just for structural, it's for structural and metabolic. We're getting to the metabolic part soon as well. Now, S1Q3T3 might be present, but now let's talk about your T wave. Now, we already know about the tall tented P wave, hyperkalemia. But if your T wave is flat, you may be looking at hypokalemia as well. They can be hyperacute. What do we know about Wellens? We know that in Wellens, they can be inverted or bivasic. We know that in Dowitas, they can be very positive, right? They can be looking very hyperacute with broad-based and symmetrical. Now, when we come to the U wave, the U wave is an extra wave after the T wave. So let's say you've had your, let's see, where can I draw? Let's say you've had your P wave, you've had your QRS, you've had your T, then you could have a little extra one before you get your P wave. Now, this is what we call a U wave. Sometimes it's not a definite wave, it's just like a little squiggle. But what that can tell you is that there's hypokalemia. I've seen a patient with 2.9 levels of potassium that presented with this ECG. Because ECG is one of our triage tools, you may be able to pick it first on the ECG before you pick it up on the bloods. Before your blood results come back. So, you can find this in hypokalemia, you can find it in hypomagnesemia. Also, don't forget your scooped segment, which can also look like a U wave, which occurs with digoxin use, right? Now, we move on to this wave, J wave, Osborne wave. I've done a lot of reels on this, a lot of short videos or shots on this. Your Osborne waves when present, I know a lot of people see Osborne waves and they say, is this a bundle branch block or is this early repolarization? J waves are very classic, but with your clinical context, even if you did not know that was a J wave, if they tell you that the patient was hypothermic, like they did the temperature, and it was about 34, 35 point something, or they were out all night, or they were found in the park in the cold, and you saw those squiggles, you know those are your J Osborne waves, right? Now, your QRS complex. Your QRS complexes can be wide in ventricular tachycardia. Whenever your QRS complexes are wide, and when I mean wide, one thing I've always told myself with QRS complexes are that narrow is normal. Not every time, but we want a QRS complex to be narrow. And by narrow, I mean it should be less than 3 small boxes. If ever an ECG QRS complex is wide, then it is abnormal. Always abnormal, right? It can be wide in VT, it can be wide in Wolff-Parkinson White. What do we know about our Wolff-Parkinson White? In Wolff-Parkinson White, the PR is short. Now, when we come to the U wave, the U wave is an extra wave after the T wave. So let's say you've had your, let's see, where can I draw? Let's say you've had your P wave. There's some accessory pathway that just disjoint connection straight from the atrium, not through the regular pathway, straight to the ventricles. So, that being said, if you did have Wolff-Parkinson White, you had bundle branch blocks, you had ventricular tachycardia, which, by the way, can be very dangerous. If you have a pulseless VT, you need to shock You need to go into your algorithm of adult life support, right? And then let's talk about your ST segment. Your ST segment can be elevated. We already talked about when it can be elevated, but also know that if you have widespread ST elevation, it could be pericarditis, right? But in your pericarditis, you have PL depression before your ST segment is elevated. Now, also know that there's a big difference between a concave ST elevation and a convex ST elevation. When we are talking about J point, this helps you. I remember when I first started learning ECGs, and I took an ECG straight to my superior at the time, and I said, "Oh, there is some ST elevation going on here," and he just laughed and he said, "No, calm down. Draw a line, and this is the line I've drawn here for you." And he says, the point by which your QRS goes to try to join the isoelectric line. Ideally, your QRS should come all the way down here, right? To join this isoelectric line. So this point where your QRS stops to form a flat line is called your J point. Now, if this J point is this J point that no matter what goes on, whether the P is oddly shaped, if this J point is higher, that is when you have a true ST elevation. If it is lower, and that's when you have your true ST depression. Now, PR interval. I've said when your PR is short, right? We've talked about that. When your PR is long, there is a block. If a PR is long, there is a block. If it is depressed, what are you thinking about? You're also thinking about your pericarditis, and there's so many other ones where your PR can be depressed, but it does help you differentiate the different types of ST elevation. Now with your QTC, your QT is the distance between your Q and your T. Now, many times there's not a Q, right? So the distance between the beginning of your QRS and the end of your T. Now, when this distance is a lot longer, a lot of people I've posted ECGs when I've had, colleagues comment and say, "Oh, but the Q-tip interval is actually looking short from what you've mentioned, from what you've shown." And this is because your QT will always depend on the heart rate. And that's where the Bazet's formula comes into place. We are very lucky in the sense that whenever any ECG is printed in all the places of the world that I know, whenever an ECG is printed, the QTC is always automatically calculated for you, because otherwise it becomes QT over the square root of your RR interval. But that being said, you don't need to know the formula, please. That's not needed. An ECG is way simpler than that. What you need to know is that when your QTC that has been calculated for you is greater than 440 milliliter per second in a man, that is abnormal. If, however, it is greater than 460 in a female, then it becomes abnormal. And that can tell you about metabolic conditions like your hypokalemia. Is there a congenital long QT or a congenital short QT? Do they have digoxin toxicity? Are they on particular medications? So it can really give you a very good insight into metabolic problems. Now, don't forget your tosadis point. That is where you have, I call it the radio tune. You have oscillating wide, and it's because tosadis point is very popular because it's the end point of having hypokalemia, hypomagnesemia, and all your electrolyte abnormalities. So because of that, it is very important that when you notice a IQ, even when the patient is well, you look into their electrolytes, do their blood work. If their potassium is abnormal, you want to correct all of that, because if it remains uncorrected or they're on a particular medication that worsens the rate at which they are losing potassium or all the other electrolytes, you can end up with a tosadis point on your hand where you have what is looking like your ventricular tachycardia, or even worse, right? So, if you want to learn about tosadis point as a topic on its own, or any of the other things I've mentioned today, or you have an ECG question that you would like me to address, please comment and let me know so I can do you more of those kind of videos. Until then, see you in the next one.